So thank you for the opportunity to speak about some of the work I've been doing looking at verifying smartphone step counts in survivors of critical illness. So we know that our patients are functionally limited for many years following critical illness, and there's increasing evidence that these functional limitations are often present prior to the patient's arrival in our unit. However, these are difficult to measure. We rely on subjective questionnaires. Not only does this take up the time of a researcher and the patient in order to get responses and to enter this data, but some of these measures may lack construct validity for survivors of critical illness. There's been some recent interest in using step counts to describe physical activity in ICU survivors, using pedometers and accelerometers. However, I'd envisage that using a pedometer as a means of assessing physical activity in a large randomized controlled trial might be a limitation to this methodology. Smartphones may hold the answer. They contain many microsensors, including an accelerometer. Smartphone step counts have been lab validated against direct observation and dedicated pedometers using treadmill tests. However, smartphone step counts have never been described following critical illness, and indeed there's limited literature assessing their use in a real-world setting. So I set out to assess the feasibility of using smartphone step counts to assess recovery following critical illness, to assess the validity of using smartphone step counts compared to step counts obtained from a gold standard measure, to describe patient recovery using smartphone step counts at 3 and 6 months following critical illness, and to compare smartphone step counts with commonly used measures of physical activity in ICU survivors. I believe that it would be feasible to use smartphone step counts, that smartphone step counts would provide a valid surrogate measure of physical activity, that step counts would increase between 3 and 6 months following discharge, and that there'd be a strong relationship between existing measures of physical activity and step counts. I performed a prospective observational cohort study at the Royal Adelaide Hospital, where we included patients who were at least moderately unwell, and by that I mean they'd been in ICU for greater than 48 hours. We wanted patients who obviously owned a smartphone, who were ambulatory prior to and following ICU, and who were likely to be able to attend follow-up at 3 and 6 months. We followed up our patients at 3 and 6 months. During a lead-in period, we called the patients to ensure participation. We asked them to install the Moves app on their phone. The Moves app is a lab-validated smartphone app that counts steps. And we also mailed them a Fitbit One pedometer that we planned for it to arrive with them at least 10 days prior to clinic appointment. Again, a Fitbit One pedometer has been lab-validated against direct observation. During the 10-day study period, we used the Fitbit One pedometer worn on their hip and asked them to use their smartphone as normal. We asked them to use the Fitbit One for all waking hours. In clinic, we extracted data from the Fitbit and from the Moves app. We also extracted data from intrinsic apps on the phone. These are the apps like HealthKit, or the Health app in iOS or Apple, and Google Fit or S-Health on Android devices. We also got our patients to perform a 6-minute walk test, and we got responses to the EQ5D questionnaire. Now, sometimes our patients would come back into clinic having not used their pedometers, or the pedometer never arrived, in which case we'd send the patients back out with a record sheet to record the smartphone data and with the pedometers, with the hope that they'd mail those pedometers back to us. You see where this is going. We assessed feasibility as extracting at least 7 days' worth of data. This is one of the measures that the literature has defined, but it also means that we conclude a weekend's worth of data. We had no prior data as to the accuracy of smartphones, so we pragmatically approached 50 patients. Results of median and interquartile range, or mean and standard deviation. We plan to assess the accuracy of smartphone data and the relationships with 6-minute walk test using linear regression, and the relationships with EQ5D mobility score using ordinal regression. We received ethical approval, and the trial was registered. We approached just over 1,000 patients. We screened just over 1,000 patients, approaching 84 patients for consent. 50 patients consented. 39 patients were available for follow-up at 3 months, and 33 patients were available for follow-up at 6 months. We used this design because we wanted to simulate what a randomized control trial would look like, which is why we recruited patients while they were in ICU. It's, again, an assessment of the feasibility of this methodology. So these are the baseline demographics of our patients at consent, 3 months and 6 months. You can see that our patients were predominantly male, aged 52. They were moderately unwell with an ICU length of stay of 6 days and a hospital length of stay of around 17 days. We were able to extract 7 days of data from 64% of the Fitbit 1 pedometers at 3 and 6 months. We had a large loss of data. This is because the patients retained the pedometers, or the pedometers were lost. Even in our small study, we spent $2,500 in replacing pedometers. We were able to extract moves data from 51% of the patients at 3 months and 52% of the patients at 6 months. And we were able to extract smartphone step counts, those from the intrinsic apps on the phone, from 44% of patients at 3 months and 42% of patients at 6 months. So we had intended to use the Moves app to verify the step counts from the smartphone. However, the Moves app was frequently difficult to install on phones. It also often recorded no steps despite being installed, and despite obviously the patient actually walking places. I observed them walk into clinic for a start. And when we compared smartphone and Fitbit and Moves and Fitbit, it was obvious that the smartphone was the better, intrinsic apps on the smartphone were actually the better estimator, with the Moves app systemically underestimating step counts. However, we planned a linear regression analysis at 3 and 6 months. However, because of the loss of data, we had to change our statistical plan, and we pooled that data, which meant that we had to change our plan to a mixed model effect, and we used a generalized estimating equation to take into account repeat measures within individuals. So this is a scatter plot of that pooled data. You can see the mean daily step counts versus the mean Fitbit 1 step counts. And the generalized estimating equation is shown. This shows that the smartphone consistently reports about 70% of the step counts of a dedicated pedometer. These are the step counts by device and time period. So this is the 3-month data and this is the 6-month data for the smartphone, the Fitbit 1 and the Moves app. You can see that our patients took around 3,000 steps per day, but that there was no difference between time period or indeed between device. The 6-minute walk test distance that our patients performed increased from 479 metres to 536 metres over the 3-month period of observation. However, when we look at the scatter plots of the relationship between Fitbit 1 and 6-minute walk test distance and smartphone and 6-minute walk test distance, you can see that there was no relationship. This is the 3-month data, and this is the 6-month data, again, showing that there's no difference, no relationship. When we looked at EQ5D, the visual analog score, which is where patients score their health today on a scale of 1 to 100, increased over the 3-month observation. However, the mobility subscore and the total score didn't change. We set a clinically significant change in step counts at 600. The odds ratio for a 1-point increase in mobility score, representing a 600-step increase in step count, was 3.28 at 3 months. However, at 6 months, that confidence interval crossed unity. So in summary, we can say that the use of a pedometer and smartphone app resulted in a large loss of data, that smartphone step counts can be used as a surrogate for a dedicated pedometer, that there was no difference in step counts between 3 and 6 months, and that there were no or limited relationships seen with existing measures of physical activity. I hope you'll agree that this is a novel approach to patient assessment, providing objective data. This is the largest cohort currently that's been followed up using step counts at 2 time points, and it's the only study reporting smartphone step counts following critical illness. Our study does have weaknesses. We're a single-centre study, and smartphone ownership may vary by location. We've also reported a high loss to follow-up, with 26% of our patients being lost to follow-up by 6 months. When you couple that with the loss of data, we can only report low numbers and have had to change our statistical plan to account for this. In addition, our current criteria require patients to own a smartphone. We know that 50% of ICU survivors own a smartphone currently, although we expect this to increase in years to come. So in conclusion, I think we can say that smartphone step counts reliably predict step counts from a dedicated pedometer, but unfortunately the loss of data that this study demonstrates currently would mean that this method is not scalable for use in large clinical studies. I'd like to thank my co-authors, particularly Adam Dean, for his support, and I'd also like to acknowledge the funding that the Royal Adelaide Research Committee has provided. Thank you.
Peter Kruger.
Very interesting. Thank you. I just wanted
I don't know enough about smartphone apps, but one of the problems in this group is baseline activity before people get sick. Is it possible to interrogate the existing step count retrospectively when they come into the ICU and have a look at what they've been doing over the days, weeks or months prior to their illness?
Thank you. It's an excellent question, and I promise you that's not staged. So we have shown that we're able to extract exactly that data from 50% of the phones that we analyse, and indeed that the intrinsic apps on the phone are often active before the patient arrives in our unit. So yes, we are able to do that, and we've just built a smartphone app that works on both Android and Apple that will do that job for us. We worked with some digital forensic scientists to try to extract that data, and I was more successful than the digital forensic scientists at getting data out, and my computer skills are honestly not that good. So
I'm a little wary of you now, a lot of sympathy for you. I just get an idea of how much is that you're working. You have a lot of co-authors, and you know, how many patients do you actually, you know, personally went hunted down, that sort of stuff.
Yeah, of
Thanks.
course. So lots of people in this room will tell you that if you want to start a PhD, that you should take a supervisor's idea and run with it. I didn't take that advice and persuaded Adam after many months that this idea was something that was worth running with. So I suppose the concept is my idea. It's been refined a little bit from some of the decisions that I made in the early days. From a running of the study point of view, I was fortunate to receive funding, and Matt Summers, who's sat behind you, was very helpful in being able to screen the patients. However, I would go and hunt them down to consent them, and that often meant traipsing to wards, and often the follow-up happened at their home. So I'd often travel out to their homes to get them to do a 6-minute walk test on the pavement outside their house to try to keep our numbers up. Which the joys of research. And I had a medical student who helped me with some of the data inputting, and Mark Finnis was very kind to help me with the statistical analysis.
Sam, got a question on the ethics of the study.
Yes.
Smartphones obviously contain a wealth of information, personal information.
Yeah.
What issues did you have to consider with your discussion with the ethics committee about accessing patients' phones and the information on it?
No, of course. Yes. This caused me a lot of problems, and it took me about 6 months to get my ethical approval. So accessing data on smartphones is controversial. I had to get written informed consent from my patients, so they had to give me consent to be able to access this data. The ethics committee wouldn't allow me to get surrogate decision makers to allow me to access this data for obvious reasons. The concern being that you find some illegal activity, or you can pinpoint something that you didn't want to. I think if in the future, if we can prove that these are useful outcomes, that the health app will allow us to extract this data, not necessarily, so it's anonymised data from these patients, to allow us to make treatment decisions. If we can prove that to be a benefit, then there's an ethical argument to allow us to do it. However, we're not at that stage yet.